Okay, let's get started. We're on chapter 49, which is page 1153. We're going to talk specifically about type 2 diabetes, but diabetes in general is one of two issues. We have an issue that there's insufficient insulin being supplied to the body, or there's just poor use of the insulin that is available. From the physiological standpoint, that's all you need to know. These are the objectives for learning about type 2. You can read them on your own. Okay, so when we're talking about type 2, we're talking about 90 to 95% of all the diabetes that's present in the United States, meaning that, only about 5% is actually type 1. There are certain things that lead people to develop type 2 that you should be aware of. Family history increases your risk. Obesity, because it increases the resistance to insulin and suppresses the production of glucose by the liver. It's crazy when we look at type 2 diabetes, how it's skyrocketed, and the fact what we know is that it actually exceeds more than $174 billion a year to take care of people who have type 2 diabetes, and right now it is the leading cause of adult blindness and end-stage renal disease. These just outline comorbidities that tend to lead to or are the result of type 2 diabetes. We've talked about these extensively in class. This just kind of outlines what happens with diabetes. As we've already said, the pancreas does not secrete enough insulin, so there's not enough insulin to take care of the needs of the body, or a lot of times the cells actually have what we call insulin resistance, and this is often the case in what we call type 2, insulin resistance. There are the issues of where we have inappropriate production of glucose by the liver, and then people develop what we call a metabolic syndrome, which is a conglomeration of symptoms that lead to type 2 diabetes. This is a great picture of type 2 diabetes, okay? So let's say that we eat something, we'll say blueberries because the marker's blue. The stomach digests it. The stomach then releases it in the form of glucose over into the bloodstream. So now it's in the blood vessel. All right, so the pancreas gets the message, hey, we need some insulin. It sufficiently makes the insulin, releases the insulin, and then look, in the bloodstream, there's your blueberries in the form, of actual glucose, but then you also have sufficient insulin. They pair. This is great. They travel through the bloodstream. They go to be delivered to the cell, but then when they get to the cell is resistant and will not take it up. What happens then is the glucose increases in the blood. And so then if we did a blood sugar level at this time, it'd be elevated because the cells have been become resistant to the uptake of the glucose. There's a great chart on page 1154 that does actually compare type 1 to type 2, and we are just focusing on type 2 for NP2. Okay, so we're just focusing on type 2 for NP2. So prediabetes is when someone has an elevated glucose tolerance test or elevated fasting glucose, okay? And then it gives you guys values for what would be considered pre-diabetes. What you guys are going to realize is that we looked at the signs and symptoms that are on page 1157, and it pretty much just says, hey, most people are asymptomatic, but they can be like one in that you have the 3 Ps, polyuria, polydipsia, and polyphagia, okay? They are more prone to having infections. Notice the wounds don't heal as quickly, maybe some weight gain, blurred vision if they've developed a retinopathy, fatigue, and these are some of the signs and symptoms. We diagnose someone For type 2, if they come in and they have the classic signs and symptoms of diabetes, and their blood sugar, just a random, not fasting, but a random stick is greater than 200, or they have a fasting greater than 126, or their oral glucose test increases their glucose load, or if their hemoglobin A1C is greater than 6.5. If someone comes in, though, and they have these classic signs and symptoms and elevated testing, they do have to have repeat testing to confirm. The only time we do not do repeat testing to confirm is when they come in with hyperglycemic, in a hyperglycemic crisis. You know, it's so severe, the readings are so severe that they come in what we consider a hyperglycemic crisis. We need to remember that diabetes is a chronic disease. It is a chronic disease. When we're looking at diabetes and what's our goals, we want to decrease the symptoms the patient's having, promote well-being, make sure there's no complications of hyperglycemia, and really prevent or delay the onset or progression of the disease. And there's a lot of different ways to do this. And this picture is just showing that. So for type 2, it is extremely important that we recognize and stress the fact that we need to focus on diet, that we need to focus on exercise, and that we also need to focus on the patient having an ideal body weight. So an ideal body weight, okay? Ideal body weight. We focus on these, there are times when people can delay being placed on medications. But if not, then there is medication available. Our goal is to keep their hemoglobin A1C less than 7, to keep their pre-meal glucose less than 100, and their post-meal glucose less than 200. This is just showing you, and I actually think this is a great picture. For instance, metformin works in the liver. Your sulfonylureas work in the pancreas. Metformin can also work in the muscle. And so it shows you where some of your different medications actually work. Next are the pages or the slides that are on the oral anti-diabetic drugs. You guys can read, so I'm not going to sit here and read through these. Really important stuff that makes the drugs stick out, I've actually tried to bold, so focus on those. So for instance, what do you want to know about metformin glucophage? It decreases the production of glucose in the liver, helps with the increase of it in the intestines. It's not supposed to cause hypoglycemia. These are some of the side effects. The big thing here is that you have to hold it if someone's going to take contrast media 1 to 2 days before and after procedures. This is your slide on glipizide, which is glucotrol. It has many other different names. The big things about these are when you take them. This has to do with how they work. Okay, so look, these guys work very differently than metformin that we just talked about, right? It actually stimulates insulin secretion, okay, thus increasing insulin levels. So you want to take these two drugs very closely to meals, okay? You take these drugs very closely to meal. These guys do cause hypoglycemia,